Well, we have the grand round this time on the behalf of Dr. Leyla AlDjasim, which I have the honor to be chairman in the division that she partially, because she belongs to comprehensive, but she's a really glaucoma specialist. And I present her many, many times already, but the things that I want to see is that she's an excellent consultant. She knows how to manage clinically the patients very well. And she has a magic touch for genetic patients. So I'm honored to have you here and presenting to you in this grand round. I will let the time to Dr. Leyla. Thank you, Leyla.
Assalamu alaikum. Today, Grand Round, we are keeping it with the time and we will talk about preventive medicine. What's preventive medicine? It's the prevention of occurrence of a disease through early detection, through screening, through collecting health data at a population level to formulate data-driven policies. Several factors play a role in initiating national screening program, including prevalence of the disease, a socio-economic burden, and the competency of the health system. The reported carrier status for Mendelian disorder in the range of 5 to 15% are sufficient to justify newborn screening and early treatment, or a community-based education and career testing. At the end, we'll see if we meet this criteria or not with congenital glaucoma. In Saudi, to date, there are two major screening programs that is active and successful. One is screening of a newborn for metabolic disease, inborn metabolic disease, and the other one, an endocrine, and the other one is the premarital screening program for hemoglobinopathies and infectious disease. They have reviewed the result in 2009. In 5 years, they have seen that the overall reduction in marriage of a patient at risk was from 90% to 73%. And the program, although it's mandatory for everybody who wants to marry, but the cancellation of at-risk marriages is voluntary. So what happens when two people at risk want to marry at risk of of hereditary hemoglobinopathies, they will get genetic screened, and then they will get genetic counseling. It's up to them to cancel. And they have noticed in 5 years, there was a 5-fold increase in voluntary cancellation of marriages. Congenital glaucoma, we have seen all these patients with severe corneal opacity, with multiple surgeries. It's this one, I think. Sorry, pointer. Okay. With multiple surgeries, filled tubes, or two patients as young as 8 or 10 years with severe disc damage and even vision loss. These are the normal criteria. Whatever is not in this category raise the suspicion of congenital glaucoma. And the iris should always in congenital glaucoma is usually have an anterior recursion. It's either flat or concave. We had a review of 308 primary congenital glaucoma patient record, and we found out that 96% has a bilateral disease, 37 had more than one family member affected, and 20% come from cousins' marriage, and 42% had a family, their parents are not blood related. So almost half of the cases, either they know that they are relatives or they suspect that they might be relatives, the parents. 31% of the eyes had a severe glaucoma, and 15% of eyes had absolute glaucoma. And patient needed on average 2 surgeries over 19 years of follow-up to control their disease. Some of the cases needed even 10 surgeries to control their disease. We have found out also that 23% had a best-corrected visual acuity below 20/400 in one or both eyes, means legally blind here in Saudi. And the patient has lost vision over a period of follow-up around 12 years. So they lost their vision while they are on follow-up and management. And Dr. Malik has published in 2017 a report claiming that one patient of primary congenital glaucoma need 20 to 23,000 US dollars for treatment per year, which is around 80 something thousand real. So the best thing to do, instead of managing these cases, we have to prevent congenital glaucoma. The first report of genetic predisposition to glaucoma was published in 1842, so almost 200 years ago. Jumping to 2024, this is a full review about the genetic maps of childhood glaucomas. It can come as autosomal dominant, recessive, or sporadic cases. The most prominent genes in autosomal recessive, CYP1B1 mutation, which with cytochrome P450, family 1, subfamily B, member 1. CYP1B1 mutation, just remember it because the rest of the lecture will be around this gene. CYP1B1 defect will cause underdevelopment of the trabecular meshwork. There is LTBB2 also causes autosomal recessive congenital glaucoma. It causes only elasticity disturbance in the ciliary body, and the function of the trabecular meshwork will be affected. It only was found in a few families in Iran and Pakistan and gypsies. As of the autosomal dominant, TEC and the ANGPT affect the endothelial function, and FOXC1 is more with anterior dysgenesis like Axenfeld-Rieger, and myocilin is more with the older patient, juvenile open-angle glaucoma. And these also can be found in sporadic cases. This is a study, very nice one, in 2016. They compared the severity of congenital glaucoma, primary congenital glaucoma, with genetic data with histopathological data. And they have found, and anybody knows how? Okay.
Or the other option is Ali.
Yeah, this one doesn't work. Okay, so no problem. The photo on the right is where CYP1B1 mutation is there, and as you can see, there is no Schlemm channel apparent along the deep limboscleral tissue. While in the milder cases, we have just taking off a membrane in the just a canalicular tissue, and they found no CYP1B1 mutation in this photo. And I think Dr. Deepak here, Dr. Shawan is here, pioneers of the congenital glaucoma here in Saudi. And if they remember, like in the 90s, it was claimed that there is in congenital glaucoma that we have a membrane covering the trabecular meshwork. And that's why goniotomy was a very easy procedure and effective. Yes, okay, it was in Europe. Here in Saudi, as I'm reviewing the old file, goniotomy was. Okay, thank you very much. Goniotomy, because it's a thickened membrane that they will cut, and then you will have an open trabecular meshwork. While in CYP1B1 mutation, you don't have a trabecular meshwork, so goniotomy wasn't working at all. CYP1B1 mutation is more in the Middle East, in the Gypsies, Middle East, Iran, India. And I read some history about it that it started in the northern India and then migrated to the Middle East. Then it went, these Indians went into Eastern Europe, and they were the Gypsies, and because of war and famine, they were pushed into Portuguese, and maybe from there they went to Brazil. As you can see, this is the percentage in the Rome, which are the Gypsies of Europe. It's almost 100% causative, the CYP1B1 mutation of their congenital glaucoma, while in US and Japan, it's only 10 to 15% of the cases. And as we saw that they don't have trabecular meshwork, they have the most severe glaucoma and most severe outcome, the same as we should see in our patients. And from all publication in Saudi from the 90s to today, all cases were linked to CYP1B1 mutation in like 75, 80, 85%. And when we study the pedigree of our patients, we have seen either it's autosomal, recessive, or sporadic cases. We don't have autosomal dominant here in Saudi, primary congenital glaucoma. We recruited from the clinic 379 families. We examined just one patient from each family. We also subjected them to genetic counseling, and we have found out that 81% of them had CYP1B1 mutation, and 95% were homozygous, and 81% of them had the G61E mutation. So if 81 of our patients are autosomal recessive disease, it's very easy to stop the disease in the future generation, either through premarital testing and prevention of career or disease and career marriage, or for the family who are already married, we can advise them for the PGT, the pre-implantation genetic testing, IVF. These are some publication from the Saudi Genomic. They studied whatever genetic data they have, and they found out that the combination carrier frequency for 3 mutations in CYP1B1 was 0.47, means 4.7%. And they have that the highest carrier calculated for a single gene mutation was 1.5%, and it was the G61E. Again, in King Abdullah Research Center, they have found out that number 6 in their diseases that were tested for genetics was ophthalmology diseases, and number 6 gene defect was CYP1B1 mutation, with around 7% of the cases in the disease and 6% of the cases had the CYP1B1 mutation. Of course, these are all genetics from all around diseases that like hereditary diseases. It's not only ophthalmology diseases. And in this publication, 2024, they blame consensuality to have a higher rate. That's why we have a higher rate of autosomal recessive diseases. Like they claim 50% of the population is in consensuous marriage, and that 80% in some areas, and most of them marry their first cousin. Of course, this is changing more and more. And when they calculated the risk of having autosomal recessive disorder in the next generation, it was 3.1%. According to the prevalence of congenital glaucoma here in Saudi Arabia, we calculated by Hardy-Weinberg equation, the estimated carrier rate in the community. So if we say that the incidence of primary congenital glaucoma is 1 in 2,500 live births, as it's mentioned in all the latest publication, and 85% of our congenital glaucoma are due to CYP1B1 mutation, the carrier frequency would be 3.6. It's almost the same as with their proposal, 3.1, 3.6. In the US, Wiggs has studied in 2014 the carrier status in the state. And based on their disease frequency, he calculated the carrier. Of course, they have 1 in 10,000 primary congenital glaucoma per live newborns, okay, which is 4 times less than our population. They have a prevalence of CYP1B1 related primary congenital glaucoma, 15 to 20%. Again, it's 1/4 of our frequency. So they expected the CYP1B1 mutation carrier frequency would be 1 in 112. That's mean less than 1%, not as with us, more than 3%. So what he did, he tested 250 healthy participants with no family history or no previous history of a glaucoma. And he found that that 4.4% were affected, were carrier, with one of the mutation of CYP1B1. So they found that the real carrier status in the state was more than five-fold than what is calculated. So if we trust their finding, maybe our carrier state would be 15 or 18%. In KKESH, we examined the carriers of CYP1B1 mutation in our patient genotypes patient families. Up to date, we recruited 447 potential carriers. Only 288 were genotyped. And we found out that 70% of them had a heterozygous CYP1B1 mutation and 22% were negative, which is really for any autosomal recessive disease. We have 25 affected, 50 carriers, and we have 25 should be non-carrier, almost the same. So, unaffected homozygous, I will come to it later on. Yeah, some of the unaffected normal people had a homozygous. Okay. So, how we can, as we said, because it's also autosomal recessive, we can do very easy premarital testing and prevention. But there are too many tests in the market. Each one has a different cost, has a different result and power, and what we can understand or what we can manage. Okay, so there is the whole genome sequencing. It's the most expensive, too many data, we don't need it. Whole exome sequencing, it will examine the protein coding genes, and it's around 1,200 riyal, and it's available in the market, but there is none. I looked actually, and I didn't find on the websites of there is the Genotech, there is Al-Burj, Al-Habib, they all do the genetic testing. They don't have anything about glaucoma. But I asked 2 years ago in RSOS, and they confirmed that, yeah, they have it. And the one gene, they said it can cost between 400 riyal and 700. And the whole genome sequencing around 1,000 to 2,000 riyal. Targeted gene sequencing panel, when we put the genes that we need to be tested, it depends on the population, depends on the disease that you need to know. And we have a single gene. And a single gene might cost only 150 riyal. In an institute outside, it can cost 300 to 400 riyal. It's very simple. So what we can, as we can see in our result, 77% were cleared, genotyped by just two genome mutations. So we can do for our patient the whole genome sequencing, and for the carrier, we can do for the just single gene testing, the one that is positive. And until we will find out, like this project is still to be continued, until we find out more genes, and then we can do a targeted gene panel depending on our population. So the genetic testing is available. It's not expensive. It's easy to be done, but do the patient will accept to do it or not? In 2021, there was a publication about, as I said, one of the most successful prevention programs here in Saudi Arabia, which is the premarital testing for hemoglobinopathies and infectious disease. And they found out that although everybody heard about it, okay, only 9% had a good understanding about it. 50% knew fairly about the project. Of course, the predictor for the knowledge was a college degree, high socioeconomic, female, previously married people, and adult. The majority, 83%, had a positive attitude toward the impact of the program. But as they said, action are more powerful than the word. And they found out that out of the engaged, 3,900 engaged, only 73% has undertaken the screening program, and that 98% has married even before the result has came. So as I said, it's mandatory, but it's not compulsory test. In KKESH, we did a review and we saw how much the patients are agreeing or genetic testing, and 98% were very supportive and very happy to undergo it. And most of them, they ask if the government can do something, the awareness, the testing, without them putting any effort. Only 73% agreed to share their information about the disease with the family, and 69% say that they don't have adequate information. As I said, we recruited or we genotyped 308 families already. So what will happen usually in the clinic, we recruit a family that we think that they have primary congenital glaucoma, and we send them to a genetic counseling, and they will educate them about everything. And then when the result is there, again, they will genetic counseling them about the result and its impact, asking them to bring their brothers and sisters and immediate family for the testing. So what happened? After the 803 families, only 216 family came for the test. And the number of the patients that approached was 447 only. So that's around 2 persons from a family. I think it's very low number actually. So 20, as I said, Dr. Khalid has asked me about the homozygous. So the other part of preventive medicine, we said either through premarital testing for patients with a high carrier of congenital disease, or through early detection. And when we did the carrier testing here, 20 people unaffected, not known to have a glaucoma, never tested, they had homozygous CYP1B1 mutation. And 17 of them today that we examined, and we found 2 patients of them having glaucoma, and they are not aware. The people that have a homozygous, they were between 2 years and 35 years. So we are talking about children, and if you worked anywhere other than KKESH, you will notice that congenital glaucoma can be coming very mild, and the patient will come to you during early adolescence or late childhood complaining of loss of vision in one eye. And it will be congenital glaucoma, but because it's mild, it's went undetected until later in life. So maybe by carrier testing, we can find more and more of homozygous carriers or homozygous affected, and then we can examine them. And even if they don't have a glaucoma now, because there was a publication from KKESH and Kick Saud University that claimed that 80-something% of primary primary juvenile open-angle glaucoma, they have a CYP1B1 mutation. So as we said, juvenile open-angle glaucoma can go unnoticed until there is a vision loss in one or both eyes. So regular screening of young patients in a family with a glaucoma is not a common practice here. Usually they say, yeah, his eyes look normal, no need to examine him until the vision will be lost, and it will be too late. So screening for a common genetic mutation, because juvenile open-angle glaucoma, a relative of primary congenital glaucoma, can spot people at risk and advise them for regular screening. And CYP1B1 mutation usually claim that it has incomplete penetrance. So you have seen patients where they have just glaucoma stopped, their pressure became normal after a few years, okay? Or maybe patients who have a very low intraocular pressure, but still their disc is damaged. And some of them just have homozygous mutation, and they have a normal looking eye, normal examination, normal disc, normal angle. And there is also a possibility of presence of modifier factors, And since early 2000, people started looking into this thing, man, no result yet. And we have done a study here 10 years ago in KKESH. Also, it went nowhere with the modifier factors. Okay, so as we said, we have to initiate a government-based education and career testing program. We have to have 5 to 15% careers in the community. And as we can see, it's not that much. It's only 4% when they are, 3% for any autosomal recessive disease. You have to have no therapy available for that disease. And primary congenital glaucoma, mostly, as we said, it can be very mild and patients are living very well. It's a problem that being in a tertiary care center and only the badly managed cases that come through. Now in KKESH, in December 2023, we had 2,920 cases of primary congenital glaucoma. I updated this information in September, and we have now 3,094 cases with an increase of 144 during 9 months. So diseases are more and more. What we can do for our patient, we have a very efficient genetic counselors, Abdul Wahab and Arij. These are their information. I hope they are okay with sharing them. You can ask them anytime. They do very nice pedigree. Like for me, if I see this patient, the last one, and his mom and dad having the glaucoma, I might think that it's an autosomal dominant, and I would treat him, I would think genetic-wise in another direction. But mashallah, they have done in 4 generations, and they found that the pedigree, and they can guide you. And as we said, 80-something% of our patients is only one gene mutation. And then we can advise them to do the testing. Our result for genetic counseling, that 23 of our patients who tested positive for CYP1B1 mutation, they brought their spouses for a carrier testing. 3 families with a child affected with primary congenital glaucoma were referred for PGT, but still no marital testing yet to date. Inshallah, they get married, our patient. Thank you very much. I will leave you with two information about CYP1B1 mutation. One, it expresses itself in the brain, in the lung, in the breast, and the ovaries. And they found out that it causes detoxification of precarcinogenic. So these patients might be more prone to cancer. On a better note, people with dealing with this cancer, they're looking for doing genetic engineering for CYP1B1 mutation through CRISPR. But would it help our patient? Because we have seen that their trabecular meshwork is not developed. I don't know how genetic engineering will work in the future. Inshallah, you will be sending more and more patients for genetic testing. And Abdul Wahab and Arij are here to help our patients. Thank you very much.
This now, I got it. Thank you, Leyla, for such an amazing lecture to give us such an update in something that I think is very, very harsh, genetic here. I don't think that all of us are so well prepared. And we are dealing with this reality in Saudi more than in any other place, at least in my experience. We don't have this situation.
It's at least 4 to 10 times more dominant than in Europe, in Western Europe, or in America.
Indeed, yeah. Indeed. Any question from the audience? Yes. I'm gonna give. You think? Yes. This one for sure it works. It's working.
Thank you very much for the presentation. First of all, you mentioned about panels. Why do you want to use panel testing?
As I told you, here in Saudi, they don't have a glaucoma panel. Nobody, genetic labs. Okay, so they when I asked them about if they do genetics for glaucoma, he showed me all the genes and he said use. So I think it's cheaper to use panels targeted to what you need to do,
No,
like
why do you
mycelium,
need to use the panel for what?
like screening for genetic screening. Instead of I'll do the whole genome, whole exome sequencing, which causes a lot of money and takes a lot of time. If I know what's there in the community with gene, it will be easier, I think.
If you are doing Sanger sequencing and you are detecting the mutation in more than 81%, the question again, why do you need a panel? To test for other genes, you mean?
For other genes, we don't know
Okay.
what yet, because this is a very, as I told you, we have 3,000 now per congenital glaucoma in KKESH. We
Right.
tested only 300 something. So
Okay. So
we don't know what's the future.
nowadays, whole exome sequencing is cheaper than panel.
Okay.
And it will be a much better option. You will be able to look for genes like LTBP2.
Okay.
In cases of autosomal dominant, I don't think you have any dominance
No
here,
dominant,
so
yeah.
you would not. We eliminate
LTBP2,
detect
I
one.
think you tested it in university and it was negative.
Yeah,
and
for
it's
some
only
autosomal dominant.
many studies they like claim that there is no obvious correlation between it and primary congenital glaucoma. It's only in
Right.
a few families worth.
And
Yeah, we don't know what would.
the
Yeah.
exome will help you also to find novel genes. Okay. The other thing is the myocillin. Myocillin is start gaining momentum, especially some people suggested that it's a modifier gene for CYP1B1. Okay.
Okay.
And there are like 3 papers which mention patients with CYP1B1 and myocillin. Myocillin is a gene
So it's
mainly
modifies
involved.
mean it
Yeah.
suppresses congenital glaucoma.
Right.
Okay.
And basically, myocillin gene, it's a gene involved mainly in adult familial primary open-angle
it's
glaucoma.
autosomal dominant or sporadic.
No, it's familial primary open-angle glaucoma. Usually, myocillin is associated with that. Finding a novel gene, so you have 81%. The plan for the 19% is to do what? Exome or?
Exome, yeah, whole exome
Whole
sequencing,
exome.
yeah, was.
Okay, and when you mention about the homozygous CYP1B1 in unaffected individual,
Yes.
are we talking about juvenile open-angle or PCG?
They are carriers, okay. The problem we don't have, like, primary congenital glaucoma is a clinical terminology that it happens in the first 2-3 years of life when have the ophthalmos and everything. But we know genetics doesn't cut age. It's just because the growth of the eye, it cannot grow after 3 years. That's why they don't have ophthalmos, but they still have like the same genetics as congenital glaucoma, but with a later onset. And
because I worked on juvenile open angle, but I can't remember detecting a
CYP1B1 was homozygous
in unaffected.
No. In affected juvenile open angle glaucoma, the publication done between you and KKESH in 2012, there was 83 or 80 something percent of juvenile open angle glaucoma with no history of primary congenital glaucoma. They had the CYP1B1 mutation.
Right, but I can't remember, did we detect anything in unaffected?
I don't remember unaffected were included.
So let me clarify this. What we looked at were really the affected patients, right? People who
only
had
affected.
juvenile open glaucoma, 2015, ophthalmic genetics, I think, right? So this is different. So here they're looking at people who are quote unquote unaffected, are homozygous. They haven't developed disease yet.
Exactly.
So they have some suggestion in 7 that they might have an abnormal angle, but
yes,
for now they are disease-free.
Okay. Yeah.
Whether they're going to develop disease, we don't know.
Yeah, we had like one teenager in his 15 years old. He was started medication, okay, and one lady, 30 years old, she had a 0.8 and 7 cupping and her pressure. But if you can see, like if they just go and check their pressure, it was normal, but because we have more facilities here, we did. And the rest of the patient, we provided them with a report with a photo of their disc to monitor every year.
Yeah,
because you don't know where it
if you dig
starts.
deep in the literature, 2001,
Okay.
Bassem Bajani, big group, and I was involved in that study as well, where it's hidden in the paper, but there were 3 such patients who were homozygous, and Bassem Bajani, who wrote the original paper, came back to Saudi to hunt for those patients. And he
Okay.
couldn't explain why they were homozygous and had no disease. And when he went to see them, he went to some couple of villages on the south. These kids were now 13, 14, and all of them had high pressures at that
Okay.
time.
So no, but
So,
here like
so this is
35
known.
years old, still he's normal. Okay. And I've seen in we had the one for the modifier gene 12 years back when I examined some of the relatives that were that homozygous mutation they had. They were normal this, normal cornea, and they were like adult patients. So you don't know. You have a bomb that is sticking. You don't know where it starts. Okay, I don't know. Is it good that it starts with the severe cases early that you can find them? Because when I worked in Oman, they have a milder cases, and they come during preschool screening, and we will find that one eye is blind. They have big eyes, more than the normal diameter. So it's congenital glaucoma, but because they didn't have corneal opacity, they had a normal vision when they were young, and they only had a beautiful big eyes. And it turned to be mild form of primary congenital glaucoma.
One more question from the audience. Any other before I? Yes, Dr. Khan.
Thank you, Dr. Leyla, for a nice presentation. Actually, from this presentation, we know that the way that we are treating congenital glaucoma might not be the optimal. Like nowadays, if a patient came to the ER, I will go and see the patient. I will diagnose him as primary congenital glaucoma, and I will do the procedure. But then, are we doing genetic testing? Personally, myself, I'm not doing.
That's
And
why I'm asking.
yes, so is this program like it should be like distributed between glaucoma and pediatric? What is the pathway of a patient coming to coming to KKESH with primary congenital glaucoma?
Okay, so just refer them to just check if it is a primary congenital glaucoma, or you have like tear segment dysgenesis, other syndromatic glaucoma. Okay, and refer them to a region Abdul Wahab. Okay, and they take it from there. This is only a research project, and we are almost done with it. Okay, but it will be the pillar for a bigger program depending on the result. If we convince for the budget and everything, Dr. Deepak, Dr. Mr. they can say about it. And but even if we don't go with this, if this is today has stopped, our patient deserve to have a genetic counseling to be told that it's going to be autosomal recessive. Okay, they can do the test as I told you. When I came first here in KKESH in 2011, there was not much of genetic labs here, or maybe I didn't know. I came from Bahrain, and we had Markaz Sheikh Jawhara. She was, Allah yarhamha, wife of King Abdullah, and they had a genetic lab there. So sometimes patients were asking me, or I find more than one person, and they were young adults and they are to marry. I was sending them, and it was around 2,000 riyal, and they were telling me it's cheaper than having a child suffer like I suffered. Okay, and sometimes when patients find out that it's genetic, or when a second child will come, they retaliate against us because we didn't explain to them the possible genetics. As you can see, it's only 30%, I think, of our population has confirmed that they have a genetic, only, no, not here. Okay, it's only 30 something percent had consensual marriage, and 30% had some other family members with congenital glaucoma. And sometimes they don't think of it until they go for genetic counseling and they find out that, oh, my cousin could be the same. Okay, so give them the information. They can go and do it in the private, or inshallah, if we'll continue here and do the genetic testing, if our lab has, I think, not operational for now, we can do the test and, or at least tell them, wait until you will be cleared. Yes. Today, one patient came to me in the clinic. He's 31 years old, and he's having advanced congenital glaucoma, high myopia, like almost blind. He needs somebody to guide him. And I told him twice, go to genetic clinic. Just hear from them, okay? And today he needed B-scan and dilatation, and I told him, go to genetic clinic, and he told me he went there. And then after that, I just wanted to know, so I texted Arij, and she told me, no, he never been here. So yeah, sometimes you offer them the information, they don't want it. And as you see with the premarital, they are, first of all, it's about thalassemia and sickler, and it's about HIV and hepatitis. You don't want it to be in your family, right? And still 98 patients from 5,000, it's still a high number, went into marriage without waiting for the result to come. And 73% is still married, even though they told them that your marriage carries a risk. So at least we'll give them the information and they have to accept it or reject it, right?
Let's see the question of Dr. Kirat.
Yeah,
Yes.
thank you very much for your lecture. It's really an eye-opening lecture. And the points are really frightening. If I understood some part of your lecture is that there were people of normal IOB and with a disc that is 0.2, for example, or 0.3, and yet they were glaucoma patients.
They carry the gene.
They
for
carried
primary
the gene.
congenital.
So
Still, they are not glaucoma.
I mean, how people are going to react to this? I mean, you mean that we need to screen everybody? Because if for example, if one comes to ER,
no, at least the relatives of, because
let's assume that we have no information about any relative who has any glaucoma, which is very likely to happen in many places in the country. Let's say that the history is unknown, and yet you examine someone and the disc is like that and the IOB is like that, and the gene is there.
If you have a family history, I think it's
let's
good
forget
to,
about family history, because let's say that we know nothing.
Actually, in few generations, if you carry the gene, you would have had somebody with the disease, or maybe they didn't have the disease. Maybe they carry some modifier in there, right, doctor? Yeah, they can be like I'm homozygous, never had anybody in
You
the
see, the
family.
thing
Like
is,
it's a bit.
usually when you set up a testing policy for routine genetic testing, you go with the carrier rate, right? So if the carrier rate is about 6%, really it's not justified. Do it routinely for everybody.
Exactly. Yeah.
And also an important point, usually for any type of disease where there are more than one gene or more than one clinical presentations, it's very important to have a pipeline for testing in order to get to the results quickly. Like, for example, for PCG, the first thing you do is a simple Sanger testing for the most common mutation.
Yeah.
The next thing, if that's negative, then you test for the LTBB2. LTBB2, it's a little bit different story, but it's a gene also involved in primary congenital glaucoma. If that's negative, okay, then you go for exome and look for other genes. And maybe if that's also negative, then if you want to do it as a research thing, then you do whole genome sequencing and try to find the gene. And so, I mean, that applies for any genetic disease with multiple genes and multiple clinical presentations.
One point, if I try to get the information together from Dr. Khan, from Dr. Kirat, and what I'm hearing about the genetic test, and I don't know about this, when you have a patient that it comes to our place, in which percentage of a new patient coming to we should do a genetic test, even if the examination is suspicious, for example. We have to do the test in every patient, in 50% of the patient, in 6% of the patients.
Okay. No, you have to confirm that they have primary congenital glaucoma first, or juvenile open-angle glaucoma with the family members. Okay. So I think if you are suspecting that there is, for us, it's not very easy to find out that if they are really glaucoma. Like, how many times in your clinic you will ask them, do you have Maya Zarga? And they will tell you, yeah, my grandmother, my mother, my father had done Maya Beda surgery. Mm-hmm. So yeah, maybe we have two genetic counselor. They are very efficient. They know how to dig into the history. They are trained to get information from the patients. Okay, better than us. Yes, we know we can give them a little bit of counseling. Okay, but for us it's general idea. But no, we don't refer everybody, but primary congenital glaucoma, because it's 3 point something% of the population carry the gene. Okay, and we have it in it's 1 in 2,500. I think it's 0.4% of the population have primary congenital glaucoma. So if you have such a case, it's no problem. Stabilize him, send them to genetic counseling, and when we suspect we have a glaucoma with a disease, yes, we definitely we have to refer them. As for the testing, this is second step. And Doctor,
if I may add, if I may add a point, for example, yes. If you say that so and so of the population have congenital glaucoma, so this is not accurate, because by saying so, we assume that everyone in the country gets access to the medical care, and then the glaucoma is either confirmed or excluded, and then we get a percentage. But in real life, there are a lot of people who cannot get access to the hospital, and yet they have congenital glaucoma and other diseases, and then this makes the ratio inaccurate. My question again, I go back to the same question, is that someone who has, we know nothing about the history of glaucoma, yet the patient walks, subject walks with what looks like a healthy disc and normal IOB. Based on what I hear today, I think everyone needs to be screened.
No, I got your question, but Dr. Khalid didn't answer it.
I will answer the question, Dr.
No, just if can I have homozygous without having for homozygous without any family history? I think we cannot. Yes,
that's rare.
Yeah,
no, it's not without family history. Without, I'm saying we don't know.
We can ask. We can ask.
Sometimes you ask and they don't know. They will not answer you.
Well, I will answer your question.
This will be points. Very important, because we have 5 minutes left, and we need a clear answer. Yes. Please.
To answer your question, 2 important points: clear clinical picture, family history. Period.
Yeah.
That's it. Well,
and then refer them for genetic.
I think this is very clear. Dr. Mesh.
Just like to know how many of your patients with unilateral congenital glaucoma presented with positive genetic testing?
With the CYP1B homozygous, it was 4% unilateral. There was 96% bilateral and 4% unilateral. These are confirmed to have CYP1B1 mutation. We measured to date 14 common genetic mutation that was published. Okay, and there are they claim that there are 130 type of CYP1B1 mutation. So that's why we're gonna do, as Dr. Khalid said, through the whole genome sequence, the whole exome sequencing to find out. So 4% of unilateral glaucoma, they have and I know congenital glaucoma is very big, right? You have many patients that you have done for them just one eye goniotomy, one eye on medication, and they are living happily since 30, 40 years. And some of them you put 2 tubes, try CBC, and one eye will be blinded and the other eye will have very mild glaucoma. There is something strange about the CYP1B1 mutation, and there are things in our body that modify it.
I have one question to Dr. Khalid.
Okay.
Now the genetics testing is become one of the available facility, and I think with time it will be very available in any lab.
Yeah.
It's like the CBC. It will be.
Yeah, it's available in Burj.
To the best of my knowledge, there is a program in UK for oncogenes where they do testing for those one who's willing to know if they have any hereditary oncology situation. Do you think the genetics testing, Dr. Khalid, will be available for every disease in the future or not?
I think eventually things will develop at research and then they will move to diagnostics. So it's going to be like research and development. And it's always better that if research is reflected for the benefit of the patient rather than we are just doing research for the sake of research. And so these types of testing, like whole exome sequencing, initially the test was like $10,000 for one sample. And then it became cheaper. It became $3,000.
$600, yeah.
Now it's, I think they charge around about, Centogene charges around almost like $1,000. We found places, reliable testing places where they can do it for almost like $100 now because the competition is so high. But with these types of testing comes, of course, these types of testing have primary analysis, secondary analysis, and most of the commercial lab, they do secondary analysis. But usually, if we want to introduce the tests here, I believe with tertiary analysis, which involve an individual analyzing the data in the context of the clinical picture presented by the patient.
Yeah.
Because exome generates data more than the usual regular testing. So if you are doing primary congenital glaucoma, you test for CYP1B1, you find the mutation, that's it. But if you're dealing with diseases with multiple genes, then it becomes an issue.
Yeah, it's the obvious Mendelian.
But I
Just
believe
one
eventually it will
Yes,
come into...
It's about the Saudi genome. That's why it was made to study the genetic diseases here in Saudi Arabia, so that they will have a data to answer. And I think there was a Dr. Deepak, if he can, they have a lab in New York where Jewish people do their testing. I think Dr. Ed once he said, and many hereditary diseases, like they give you the maps, and then you will decide to go for it, which diseases can come. Because if we remember, maybe Dr. Rula can tell us, a lot of genetic diseases were linked to Jewish, and they have removed many of them from the map.
I'm sorry to cut. I know that is very interesting. Everybody wants to keep saying, Dr. Arola was raising the hand. This will open for a second chapter talk on genetic, if you don't mind. I really appreciate your talk, your help, your questions, and your attendance. Thank you very much, and see you in the next chapter.
Thank you.